be our facilitator. Just a brief introduction about Sir. He is the Director, Department of Lab Medicine of C.K. Birla Hospitals and B.M. Birla Heart Research Center, Kolkata. He has done his MD Biochemistry from Bardhaman Medical College, and after that he went ahead and completed his DNB in Biochemistry, besides PG Diploma in Diabetology and PG DHHM in 2019. He is the President of the Association of Clinical Chemistry and Lab Medicine Practitioners, that is ACCLMP, and also our NABL lead assessor. He has many publications to his credit in many peer-reviewed journals, and he has been an active participant and a speaker in many national and international conferences. Over to Sir for our next lecture today on report interpretation. Thank you.
So let's straightway go to the cardiac marker. So what I was talking about, an ideal cardiac marker, what we talk about, the cardiac markers previously you used to know that the markers, the parameters which depicts the cardiac injury are called the cardiac markers. So nowadays, if you talk about a cardiac marker, the ideal cardiac marker which should be, that should have a high sensitivity. That means that should be present in a high concentration in the myocardium, and that can be released immediately after a myocardial injury, even after a small myocardial injury. So that can be, the rapid release is better for early diagnosis, and those who have a long half-life, it is important and it is very helpful for late diagnosis. So if you consider the second one is the high specificity, which is very, very much important, because in previous days, majority cardiac markers have got so many origins of skeletal muscle in brain and all other areas. So you cannot actually define that raised parameter means only cardiac injury, but nowadays the high specificity one making it more important and more valuable, because this should be present only in myocardial and absent in all non-myocardial tissue, and should be non-detectable in blood of non-disease subjects. That gives just a high specificity of the marker. Analytical parameters that should be measurable by a cost-effective manner, simple to perform, and should have a rapid turnaround time to call it an RDR marker. And last but not the least, the clinical characteristics that it have the ability to influence the therapy and ability to improve the patient outcome. That means this parameter should be able to diagnose, prognose, and everything of a cardiac injury. So that should make it an ideal cardiac marker. Now, this is what I can show you, that why the cardiac markers are coming in the blood in different times, and they are important for different reasons. So now look at the cardiac muscle cell. How does it look? Here is in the nucleus, you may get some of the CKMBs, and in the mitochondria, you may get some CKMBs over there. But mostly the myoglobins are present in cytoplasm, and the troponins are in the contractile apparatus. So what happens immediately after injury, it is the cytoplasmic markers which comes out first, and then the mitochondria and other tissue organelles, which actually cell organelles, which are destroyed, and gradually they get released in the blood after the injury. And that is why myoglobin is the first to appear in blood. So earliest cardiac marker, followed by others, and only after the total cell degradation, the cell organelles are degraded, and gradually the markers come in the blood. So what happens? These are the markers which is mainly present in the cardiac muscle cell. When cardiac muscle cell injures, it comes to the blood and becomes visible in the serum. So that gives the diagnostic importance of it, and that is why the different things come up in a different time period. Now the biochemical markers that previously we having a traditional thing we used to call a cardiac marker, CK, CKMB, LDH, and SGOT. And now it is recent we use others, particularly CKMB mass. And the most important thing is that with the champions of the time now in the cardiac troponins. Cardiac troponins T and I and myoglobins. And in future, there are some other markers coming up, which is ischemic modified albumin, fatty acid binding protein. These two are actually mainly in the market nowadays, which may have some bright future in diagnostic as a diagnostic marker. High sensitive CRP is most of our prognostic marker than a diagnostic marker. So all are the markers coming up in the market coming up later on. Now, if we talk about that, cardiac troponin I, this is the champion now. Now, every cardiac diagnosis now on the basis of these two cardiac things, one cardiac troponin T and cardiac troponin I. Now, previously also, troponin I was there. The troponin I was never considered as a very ideal marker. But nowadays, this one which is identified as the cardiac troponin I, which is human cardiac troponin I, which has got an amino acid residue on its N terminal, which is absent. This amino acid is absent in skeletal form. And that made it too much specific for a cardiac muscle. And that is why the diagnostic importance has come up. So after the cardiac troponin I detection level, we started. It starts 2 to 8 hours after cardiac injury and remains about 7 to 10 days. So it's a long-standing one. It has got a secondary peak in the later on. So it is most important one for definitive diagnosing within the golden period time, as well as if somebody, particularly in Indian condition, when majority time you actually miss the bus, you don't reach the medical unit when you have a heart attack. Mostly majority people come very late. So those cases, actually, this is one of the most important one to have some late diagnosis as well. So in the countries like India, you cannot ignore that also. So cardiac troponin T, that is also almost having the similar nature of cardiac troponin I, but it is actually remains a bit more in so far timing is concerned. But so far diagnostic importance is concerned, it also having more or less similar kind of importance of cardiac troponin I. And TROP T, the cardiac TROP T for point of care testing, it is one of the most likely choice of cardiac enzymes. Now, if you look at this, this is the thing where you can find that the initial time period, this is one, this purple one is a cardiac troponin I, and this red one is a cardiac troponin T. They have the capacity to rise very early up to the 4 hours, within 4 hours time period, and remain in blood about 4 to 12 hours, then declines and remains high above range for quite a long time period, so that this helps in early diagnosis, definite diagnosis, as well as also for late diagnosis. These are other markers like AST, which rises also at the similar time of cardiac troponin, but peaks at about 24 to 36 and gradually declines down. LDH is the low one to rise, about 12 hours it takes time to rise and stays for long. So LDH is another enzyme which actually helps in a late diagnosis of MI. Although nowadays we know that for late diagnosis of MI, we don't have any significance when the golden period has already passed by. So we always try to catch the earlier one. Okay, so always try to catch the earlier one. And the myoglobins not are present in this graph, but they are the fastest to appear. They start appearing within 1 hour. So therefore, if there is a definite sign and symptoms of myocardial injury or MI, when the patient is clinically showing MI, then if this myoglobin is raised, then definitely you can go for a diagnosis of MI. If ECG suggests with your findings, you can go for definite treatment. So the time period, which is very important to myoglobin, but myoglobin has got a definite disadvantage, is has got no specificity, and even in skeletal muscle injury also, you may have a high myoglobin. So talking about specificity, sensitivity, and timing, in every sense, TROP-I is the best one. Now you can have a look on this, all of them. CKMB useful in diagnosis of infarct and reinfarct. AST does not have a specificity because it is also a liver enzyme marker, also skeletal and muscle enzyme marker. But the TROP-I has got the complete cardiac specificity, and that is why it's considered to be the best marker. Then we come to some other cardiac diagnosis, that the brain natriuretic peptide. So it actually identified from peak brain, so that is why it is called brain natriuretic peptide. That is actually, it is mainly atrial natriuretic peptide, because this kind of proteins, whenever the cardiac volume overload goes, the atrium stretches. With the stretching of the atrium, it triggers a positive stimulus to the heart, and therefore immediately after the positive stimulus is released, the brain natriuretic peptide that releases, and therefore the condition and that ABNP rises. So if you get this, so sometimes you may get confused with what does it mean by NT-proBNP? So this NT-proBNP, if you consider with that the proBNP is 108 amino acid residue. So which, when it gets activated, that it cleaves on the 76th position. From 77 to 108, this part, and from 1 to 76, this cleaved in two parts. So therefore, the proBNP section is actually the NT-proBNP, the N-terminal proBNP, that is the 76 amino acid residue one. So what happens, BNP has got a very low half-life. It has got an extremely low half-life, so it's very difficult to diagnose or to analyze this parameter in our lab setup. So proBNP is actually, or NT-proBNP is actually the equivalent portion of BNP. So one BNP is produced, one NT-proBNP is produced, just like insulin and C-peptide. So if you diagnose, or if you analyze, or if you quantitate proBNP, that means the equal volume of BNP is also produced. The advantage of this NT-proBNP is the stability is high. It has got a half-life of 120 hours. So you get enough time to diagnose it or analyze it in the lab without getting degraded, which the BNP does not have. BNP degrades early. So therefore, a proper quantitation in lab is been very difficult. Now, markers of myocardial infarction and heart failure. So now overall, if you consider it, we consider this cardiac markers into three varieties. So one, which is use of prognosis of MI. That means these are cardiac prognostic markers, like all what I have said, HSCRP, myeloperoxidase, high sensitive troponin I, high sensitive troponin T, the fatty acid binding proteins and fragments, all. They are mainly showing the chances of developing MI or prognosis of the patient's heart condition, whether it is possible that the patient is likely to go for an MI or not. And so that is why they are called prognostic marker. Now the markers which definitely says there is a cardiac injury has happened and there is a possibility of MI are called MI diagnostic markers. These are cardiac troponin I, troponin T, fatty acid binding protein, myoglobin, CKMB, LDH, and AST. They are the diagnostic marker. Now, apart from diagnostic marker, if I consider the cardiac health is also jeopardized when there is a cardiac failure. Heart failure is a condition where myocardial injury may or may not happen, but cardiac function deteriorates. In those conditions, the missed marker is proBNP, NT-proBNP, and BNP, all the natriuretic peptide family. So this is all about heart in a nutshell, and I hope this cardiac markers are made easy a bit for you to understand, although with such a quick period of time, it is not possible to actually undergo entire thing of cardiac marker, but I can at least give a brief of idea about what are the cardiac markers, what do you intend to analyze, and what actually they signify. Now going for another organ, which is also very, very important organ, is called liver. So when we consider a liver function test, what do you mean by liver function test? These are the parameters which are tested to identify whether liver condition is good or not, and also to identify what kind of problem the liver is facing. So that is the liver function test, means all the tests clubbed together to actually identify or quantify or having an idea about the liver disorder and also which kind of disorder it is. So now just have an idea about the bilirubin metabolism, although liver is actually the kitchen of our body. So metabolism of liver is not a very easy thing to understand. So lots of things are affected when liver is affected, but still if we find it there, so when there is an extravascular or intravascular hemolysis, you get good amount of bilirubin released. This bilirubin binds with albumin because bilirubin is not water soluble, so it needs a carrier to be carried. Now with the help of albumin, it actually comes to the liver cell and gets inside the liver cell. So there where conjugation happens. What is conjugation? Conjugation means a non-polar bilirubin now binds with some polar product, and therefore the bilirubin becomes water soluble. So which one is actually bound to glucuronic acid? So it binds with 2-glucuronic acid to produce diglucuronide, and therefore the bilirubin becomes soluble bilirubin. Unconjugated bilirubin means which is not conjugated with glucuronide, and conjugated bilirubin means which conjugated with glucuronide and now becomes soluble so that it can be released through bile in the gut, and therefore a part can be released through urine. So it is basically a mechanism where an insoluble or non-soluble bilirubin made polar and therefore was soluble in water so that it can be excreted through the excreta. Now, after being it is in the biliary system, it goes to the gut, where part of the bilirubin is now acted upon with the bacteria to produce urobilinogen, and which is released through kidney, through kidney as urine, and rest of the part are released through fecal matter. Now, the most important thing is that if I go with this and I'm trying to find out this liver function test, which are the liver function tests mostly we do? We do total bilirubin, conjugated bilirubin, unconjugated bilirubin. What are the LFTs, as I have told all of you? Now the LFT is comprising of all the LFT tests along with the prothrombin time, P time we also consider as a part of LFT, and also urinary bile pigment, urobilinogen, they're all considered to be a part of liver function test altogether. So now to be in a brief, in a nutshell, should I give an idea that this is what we helps to diagnose. So these are the parameters we can take in consideration: total bilirubin, conjugated, unconjugated, alka-phos, enzymes like ALT, AST, GGT, total protein, and all. So when in case of an acute or hepatic disorder, what we can expect? We can expect the total bilirubin is high, and since it is an acute hepatitis, the liver enzymes liver cells are damaged and distorted. So the enzymes comes out along with the bilirubin. Initial part, the bilirubin which comes out in the circulation are mixed bag, because the conjugation process was still there. So when it is coming in the blood, rising the blood bilirubin condition, you get a mixed bag where you can have a high conjugated bilirubin as well initially in the initial part of acute hepatitis. So there is a confusion that happens very frequently, because we always know that hepatitis leads to unconjugated hyperbilirubinemia, but it's not so. Initial part of the hepatitis, when the liver cells are just destroyed, it is the mixed bag you can get, because the most of the part the bilirubin was getting conjugated inside the liver cell. Now with time process goes on, liver function stops functioning. So gradually we'll get unconjugated bilirubin more. But initial period, you may get very high ALT, ASTs, not very high alkaline phosphatase, almost normal GGT, and most importantly, total protein, albumin, globulin, and ratios are totally normal. Why do we do this total protein, albumin, these things? This is mostly to diagnose the chronicity of the liver disease. As you know, albumin has got a huge storage in our body. So the albumin, unless there is a severe blood loss or something, albumin doesn't get reduced, only by reduction of production. So in chronic hepatitis, you might find that the bilirubin is slightly raised with mostly conjugated or unconjugated mixed bag. ALT-AST is not that high, but GGT started rising. But the most stunning thing is that albumin goes down and globulin gets up. So albumin production gets affected, and because of a chronic inflammatory process, the globulin fraction goes high. So therefore, the very important is that the reversal of AG ratio, which is the most important sign of chronicity, particularly in these conditions. Now there are other jaundice, other hemolytic conditions, hemolytic jaundice, where you get a very high bilirubin, mostly unconjugated bilirubin. Here liver has got nothing to do, but the extra overload given to liver because of extra hemolysis, excess hemolysis. What happens? Initial part, liver can carry out this hemolysis, the conjugation, but after a time, when actually the workload given to you more than to your capacity, you actually can't cope up with that. That's what happened with liver here only. In hemolytic jaundice, that is why you will find no abnormalities in any of the parameters, only will have some unconjugated hyperbilirubinemia. Because the amount of load given through excess hemolysis, liver can't bear with it and lead to this. And last kind of this, which we actually get an obstructive or post-hepatic jaundice, where everything is ready, liver's kitchen is okay. So whenever the bilirubin is coming, is getting conjugated, but it is not getting the way to get out. So what happens in this condition? The obstruction of the biliary tract that leads to a backflow, so that the conjugated bilirubin flows back in the blood, and that is why you get a conjugated hyperbilirubinemia. And the most important sign and the most important other part which helps your diagnosis is high alkaline phosphatase and high GGT. They are mostly very important areas where you can get a very high alkaline phosphatase and GGT, just because the stimulation comes from the obstructive liver biliary tract. So these are in a nutshell of a liver disease, where liver function test gives you idea about any kind of jaundice or any kind of liver disease. Not only that, it can lead to several other things as well. Obstructive jaundice, you will always get a high prothrombin time. Why you will get a high prothrombin time? Because the vitamin K, particularly one of the most important thing for coagulation, they cannot come out through the bile duct, and they cannot get absorbed in the blood, and because it is what A, D, E, K are actually fat soluble vitamins, isn't it? So they come out through bile and they get absorbed in the gut. That is why vitamin K deficiency leads to high P time. So that is why in case of obstructive jaundice, vitamin K injections are very frequently given. Now we come with another very important organ, the kidneys. Okay, so although they are laughing, but sometimes they are source of our cry. The most nowadays with advanced lifestyle disorders like diabetes, hypertension, and on, this particular organ is actually suffering most, and they are at threat at most in our lifestyle. So other than any other parameter or heart or liver, kidney are the worst sufferer of all lifestyle disorder problems. So now kidney is another which is a multitasker. So if you want to have a diagnosis on kidney conditions, you have to check so many things. Like that, serum creatinine, uric acid, burn, electrolytes, calcium phosphate, and iron indices. Kidney serves so many functions. That is why if kidney is damaged, there are so many parameters may get affected. So that is why I kept all under one umbrella of a component of renal function test and will describe one after another. First, we talk about burn creatinine ratio. I have heard this question from several of my my juniors and others that creatinine is 5 and my urea is coming 35. Can I report? This is a very common confusion happens. So that is why I have kept this slide. Try to understand what happens. So if the condition where burn creatinine or burn or creatinine whatsoever, they are raised because the kidney condition is poor. The kidney cannot cope up with the filtration properly and the waste products are retained. Now what happens in pre-renal condition? The pre-renal means the insult has happened before the renal function starts. So these are all dehydration and all these things, renal shutdown conditions, where you will expect to get a very high creatinine urea in comparison to near normal or just slightly raised creatinine. And you will see that the burn creatinine ratio, I am sorry, it's not burn creatinine, it's urea creatinine ratio, which is more than 20:1. That happens because the pre-renal condition, GFR is decreased, but at the same time, urea has got a high reabsorption rate from proximal convoluted tubule. So what happens? Urea is getting stored from two sources. First of all, it is not getting secreted from GFR, from glomerulus, and secondly, its reabsorption is increased from the proximal convoluted tubule. So therefore, the urea is stored more than creatinine, and here you may get a urea creatinine ratio more than 20. Similar thing happens when a chronic renal problem happens. More the chronicity, less is the ratio. What happens when is decreased excretion of urea creatinine both happens from glomerulus, but as well as they have a decreased reabsorption of urea also. So that leads to urea, less conservation of urea in comparison to creatinine. And that is why in those conditions of CKD, you might find that urea creatinine ratio is even 10:1 or even maybe less than that. I have got a 5:1 urea creatinine ratio also. Mind it, please mind it, more chronicity of a CKD, the more chance of getting lower and lower urea creatinine ratio. So don't be afraid of releasing a result of 15 urea and 4 creatinine, because that might so happen when the CKD stage 4, stage 5 of a long-standing CKD patient. And lastly, post-renal condition, when there is any obstructions are happening in case of renal condition, a tumor, stricture or something, there you can find both urea and creatinine are increased, and with a ratio of 20:1 of urea creatinine more or less resolved. So this is in a nutshell to get an understanding with what is one urea creatinine ratio and how it is altered in different conditions. Now, the kidney conditions that can lead to non-protein nitrogen retention, which is azotemia. There are so many conditions that can do so, as I have discussed. First is a pre-renal causes, which may be hypovolemia, that means severe dehydration or something, GI, excessive fluid loss from gut, circulatory failure, particularly in case of heart failure, this renal shutdown, this is we can call it colloquially renal shutdown. In case of severe sepsis or in case of failure, we can get a renal shutdown condition where the renal artery is not getting adequate pressure. What happens? This glomerulus is actually in this arterioles of the glomerular arterioles, the afferent arterioles are about 50 micrometer in diameter and efferent arterioles are 25. So therefore, in the glomerulus, the capillary always undergoes a severe pressure of inbound high volume fluid and outbound less. So therefore, because of this pressure created, the filtration happens. Now, what happens in case of cardiac failure or some other cases, the blood pressure cannot generate that much so that the kidney can filter. That is the condition which is called renal shutdown. And every case where there is hypovolemia, circulatory failure, or whatsoever condition which leads to low blood pressure, low renal artery pressure, so that there is not enough pressure generated for filtration to happen. Next, this is a renal cause are acute glomerulonephritis, chronic renal disease, nephrotoxic drugs, particularly during tubular injuries. They are the renal causes of renal failure. Now, if we talk about post-renal causes, there are stones, enlarged prostate, strictures, tumors. They can obstruct this outlet, and therefore, because of the outlet obstruction, there will be hydronephrosis and gradually leading to renal failure. So these are the conditions which can lead to a renal disorder or azotemia, where the renal products are retained and causing high urea and creatinine. Now, if you talk about uric acid are mostly filtered from the glomerulus, nothing to do with filtration. And then after filtration, it again reabsorbs. Then 50% gets secreted, 40% again reabsorbs. So that leads to near about 10% excretion. But the sole source of excretion is kidney only. So whenever there is a tubular damage happens, uric acid excretion damage happens very badly. So therefore, hyperuricemia, condition which associates sometimes with renal problem or renal failure, that mostly happens because of tubular problem, not because of the glomerular filtration. So that what happens, it can be of two categories. Excess catabolism can lead to hyperuricemia because of overproduction, or when there is a renal disorder, it can lead to a hyperuricemia because of underexcretion. And all lead to gout, which is actually manifested by a production of mono sodium urate crystals, which actually called to be a toffee, which is a lead to some inflammation, a very painful condition in the joints, which called gout, and therefore hyperuricemia is one of the marker of renal disorder. Now, this is a renal regulation of sodium and potassium levels in body. Unfortunately, it will take a huge time if I consider talking about all these things. But due to all these problems, I lost majority of time over here. So I'll go through it very fast. So there are from glomerulus up to the distal convoluted tubule, there are lots of areas where actually sodium potassium conservation and secretions do take place. In proximal convoluted tubule, carbonic anhydrase inhibitors can be one of the important thing. Then thiazides, then loop diuretics, then potassium sparing diuretics. These are the areas where they actually work. And for this, actually, the sodium potassium regulation is grossly gets affected. So if you, I'm going in a hurry. So let's consider this. We'll have enough time for discussion. Don't worry about it. So these are all theory. So you can go in a hurry. That if you consider plasma osmolality in hyponatremia, there are some isoosmotic, hypoosmotic or hyperosmotic conditions. In hypoosmotic, mostly pseudo-hyponatremia that I told you last day, that in hyperlipidemia or hyperproteinemia, there is available water is very less in the serum. So therefore, as a pseudo-hyponatremia or low sodium potassium can do happen because the water available in the serum other than the protein or lipid is so less, so it miscalculates and give a low result. So isoosmotic hyponatremias are mainly analytical problems. But if you consider hypoosmotic one, this can be because of hypervolemia, euvolemia or hypovolemia. While hyperosmotics are mainly because of hyperglycemia and mannitol overdose. Now you consider a hypoosmotic hyponatremia. So there are hypervolemia where urinary sodium may more than 20. This is mostly in renal failure. Or when urinary sodium less than 10, that is spot sodium, that can happen in nephrotic syndrome, cirrhosis or heart failure. In euvolemia, mostly CR or mostly hypothyroidism. In hypovolemia, when urinary spot sodium is high, Then in these cases of diuretics, mineralocorticoid deficiency, particularly Addison's disease, metabolic alkalosis, and when urinary sodium is less or diluted, it mostly because of GI fluid loss or skin losses, which lead to hypovolemic hyponatremia. Now, in case of hypernatremia, in case these are aldosteronism, Cushing syndrome, sometimes of hypertonic fluids, euvolemia mainly of diabetes insipidus and hyperosmolar non-hepatic coma. Hypovolemia is again GI loss and skin loss can lead to hypernatremia. Now, hypokalemia, which means potassium less than 3.5, this can happen because potassium redistribution means if you force the potassium to get again inside the cell, it is like insulin or IV insulin therapy, or in case of alkalosis, where there is a K plus H plus exchange that leads to restoration of pH at the cost of hypokalemia, or some drugs. True potassium deficit can happen in case of mineralocorticoid excess, where aldosterone actually drives out potassium out of through the kidney. Maybe diuretics, potassium losing diuretics, particularly loop diuretics, starvation, GI loss, and acute tubular necrosis. Hyperkalemia can occur because of metabolic acidosis, dehydration, massive tissue hypoxia, hemolysis, insulin deficiency, particularly diabetic ketoacidosis. It can happen, hyperkalemia, rhabdomyolysis, and some drugs, obviously, which raises potassium. Now, increased potassium load can happen with potassium supplement, massive blood transfusion, etc. And particularly in Addison's disease, where urinary potassium loss has been less, so it can lead to restoration or storage of potassium in blood, so therefore lead to hypercalcemia, or sometimes excess use of potassium sparing diuretics, which can also lead to this. Now, there are pseudo hyperkalemia, as we told always, that a platelet destruction or RBC destruction, since it is containing in a very high concentration, so even a few RBC destruction can lead to high serum potassium, which is actually a misdiagnosed or interference, which leads to hyperkalemia. We call it pseudo hyperkalemia. After that, now it's time to come for calcium metabolism. It is one of my most favorite area. Unfortunately, I have to rush through in a hurry. So calcium metabolism in our body is just like the two superpowers, America and Russia, are fighting with each other, and Norway is coming to intervene. So there are three areas, three particular ones. Parathyroid, who has got a sole interest of conserving serum calcium by any means. That means when there is a hyperparathyroidism, the main role of parathyroid is to increase serum calcium by any means. That means it has to be, it may be good or it may be bad. It reduces calcium excretion from kidney. It increases calcium excretion, calcium absorption from gut. At the same time, it draws out or actually fetches out calcium from your bones. So therefore, sometimes it does some good thing, sometimes it does some bad thing. It fetches out calcium from bone, it reduces calcium excretion, it increases absorption from gut. The net interest is, by any means, it has to increase calcium concentration. Calcitonin, just the opposite. It will, by hook or by crook, it will reduce serum calcium. So either by decreasing absorption, or by increasing excretion of calcium through kidney, or by putting more and more calcium in the bone. So they are always been opposite to each other. Thyrocalcitonin, which actually comes from one of the part of the thyroid gland, and parathyroid hormone. So what happens when serum calcium decreases? A positive stimulation goes to parathyroid, so it starts its action to restore the calcium. And when there is a hypercalcemia, a positive stimulus goes to calcitonin to act on, so it increases its function to do the opposite thing. But now, in between, there is a third person who actually does something for him, does something from for the other. So it's a person like doing mutual in between these two is a vitamin D. So vitamin D has got a function. It restores calcium in bones. At the same time, it enhances calcium absorption from the gut. So, with the helping hand of the two oppositely functioning person and with a mediator, the calcium metabolism remains in our body in a hemostasis around 8.4 to 11. So, this is what a vitamin D role is there. And why I am taking vitamin D in consideration for renal function? Because other than liver, the vitamin D gets activated with two hydroxylations. First occur in liver in the 25 hydroxylation. Second one happens in kidney. So if kidney is jeopardized, this one hydroxylation will not occur and vitamin D will not be able to properly function, which may lead to hypocalcemia and which may actually lead to a secondary hyperparathyroidism by stimulating parathyroid action. So kidney is actually in role of putting everybody in a liaison, and therefore kidney condition disruption or liver disruption can actually affect so many systems altogether. There are certain causes of hypercalcemia and hypocalcemia. So the cause of hypocalcemia is mostly clinical feature is a neuromuscular complication like muscular spasm, carpopedal spasm, tetany, extreme cases convulsion and laryngeal spasm. So most causes are hypoalbuminemia, which is liver disease, nephrotic syndrome, malnutrition. This happens because calcium is always carried in blood with albumin. So hypoalbuminemia is always there. Total calcium is reduced in blood for that. So hypoparathyroidism, rickets, osteomalacia, CRF, they are the reason for hypocalcemia. Similarly, for hypercalcemia, you may get asymptomatic fatigue, malaise, weakness also, some other asymptomatic cases. But in case of hyperparathyroidism, malignant tumor, vitamin D intoxication, we are going to get it very soon actually. So all persons vitamin D you test, you will find deficiency, and clinicians are happy because vitamin D, they can prescribe vitamin D. Pharmaceuticals are happy because they can sell vitamin D. We are happy because we can test vitamin D in a high price, about 2,500. Everybody is happy, but only unhappy person is our kidney, because with a vitamin D of 15 and hale and hearty calcium and hale and hearty clinical scenario, we are prescribed vitamin D, and very soon I'm pretty sure we will end up with nephrocalcinosis very soon. Most of the person in our income near future. So leave it apart. So there's other drugs and immobilization are also other reason for hypercalcemia. There are conditions, hyperphosphatemia, where there is a phosphate is low. Lots of conditions. I think it's unnecessary to read out all this. Now, the most important, another thing which you will find difficult to answer is iron indices. So, I always prefer saying this iron indices. So, iron deficiency anemia, there are the conditions. I have been answered, I have been questioned several times how to diagnose iron deficiency anemia and what are the stages. So far I know there are certain parameters like ferritin, serum iron, TIBC, and hemoglobin. So if you want to diagnose iron deficiency, the earliest parameter to be diagnosed is ferritin. Next, serum iron, and next hemoglobin. Now there is confusion. Lots of people do have a confusion. I give an example. Suppose you are well off now, suddenly you became unemployed. That means your source of earning goes down. So first you will cartel with what? You will not cartel with your lifestyle. What you will cartel? You will take money from your bank. So first to get exhausted is your bank balance. So that is why In case of an iron deficiency, when you are deficient with iron, the first you can expand is your storage, that is ferritin. So that is why ferritin is the first parameter to be decreased. Then after ferritin, you are now going to curtail your day-to-day activities, day-to-day luxury activities. So serum iron is that part. When you're the next to exhaust is serum iron, but last to be affected is hemoglobin. Similarly, your last thing is your food and dresses, which you are actually the last thing you would like to spare. So serum iron also deficiency also happens in stages. First in storage, the serum ferritin decreases. Then you will get a serum iron also decrease, but still hemoglobin is okay with. But when finally hemoglobin gets decreased, that means all other parts are exhausted in the body, and that is why you are having a clinically effectively looking anemia. Similarly, now I am here just to give a nutshell in as a whole. What are iron deficiency anemia? The anemia we consider about the 3-4 categories. One is iron deficiency anemia. One is called anemia of chronic disease, which happens when a person is long-standing with illness. All the anabolic activity decreases. So therefore, it has a long transferrin and all other proteins are also decreased. One thing is hemolytic anemia. That anemia happens because of excessive hemolysis, or it can be of thalassemia as well, and megaloblastic anemia. So therefore, you will find that in iron deficiency anemia, you will get low hemoglobin, very low ferritin, very low iron, and naturally, if iron is low, your food appetite is high. So total iron binding capacity, or TIBCs, will be high, and folic acid, vitamin B12 may be so-so. Peripheral smear will show microcytic hypochromic anemia. Similarly, of anemia of chronic disease, we will get low hemoglobin, ferritin either or not, thus either raised or normal. But the most striking feature you will get, the any iron is also low, TIBC is also low. In both the cases, the serum iron comes low as well as serum TIBC is also low. That is one of the cardinal feature to call it a anemia of chronic disease, because peripheral smear you are getting the same like iron deficiency anemia. Similarly, sometimes you may find that I get things that, so there is an anemia patient, low iron, but TIBC is coming heavy high, very high. So sorry, TIBC is coming very low and iron very high. The first thing I ask, check whether the patient is beta thal trait or not. Because in beta thalassemia trait, you will get 10, 11 around hemoglobin with a very high iron, because it actually, the major problem with the beta thalassemia patient is that serum iron becomes very high. Naturally, total iron binding capacity will be low. And you may get microcytic hypochromic anemia or target cells. In megaloblastic anemia, you may get a macrocytic cells and all other things more or less equal, but only folic acid and vitamin B12 are less. So this is in a nutshell. If you want to diagnose the type of anemia, you can find it like this. So it will help in your diagnosis of finding the types of anemia. Now I will go for some case studies. Before I go to case study, I would ask it to open it for everybody so that you can question me after one or answer me after one another. And I would like to get the interactive session. So is it open for all? Hello? Oh, so let's see. So anybody wants to answer my question, please raise your hand. I'll allow you to talk so that we can have an interactive session. Okay. So let's start with the first one. Laboratory findings of blood and urine examination of a jaundice patient is like that. Total serum bilirubin 9.8, conjugated 5.3, 4.5 is unconjugated. Enzymes mostly will find ALT, AST are raised, ALP borderline raised, and you will find urobilinogen being positive, bile salt and bile pigment being positive. So my question is, what is the diagnosis? So I think it's a very straight one case. I don't waste my time. I don't want to waste time with that. So as you understand, it is a case of negative hepatitis. Secondly, this is what you find are mostly unconjugated. All the enzymes are normal. Urobilinogen is still positive. So this kind of condition is a case of simple case. I don't think anybody would like to answer on that. So please, if you want.
Pre-hepatic jaundice.
Yeah.
Pre-hepatic or hemolytic.
Yeah, this is hemolytic jaundice. Thank you. So next in this case, laboratory findings of blood and urine examination of jaundice patients are as follows. Total bilirubin 12.6, conjugated 12, enzymes showing alpha phos very high, GGT very high, AST, ALT more or less normal. Urobilinogen is nil. So would like to answer this very straightforward dolly question.
Post-hepatic.
Yeah, that is an obstructive jaundice. That's post-hepatic. Now I go this. This is interesting. All those after those lollipops, now you discuss with these things. I have three cases, isotope-like cases. You get the first one, where you have a total bilirubin 3.9, mostly unconjugated, as direct bilirubin is only 0.5. All enzymes are normal. Protein, albumin, globulin, all are normal. Patient 2, this is also having almost similar category of hyperbilirubinemia, but only difference is you have a slightly raised alpha phos, almost negligible, that I cannot say it's a raised one. But look at the AST, ALTs, and look at the proteins. And now let me know what are the diagnoses of these three. Can anybody please give an answer of these three? So there are three different clinical features, three different clinical scenarios. But all
case one could be pre-hepatic.
Yes.
Case one could be non-liver, pre-hepatic or hemolytic.
Which one?
First patient.
Okay, then.
Patient 2 could be hepatocellular, probably alcoholic etiology, because AST is more elevated than ALT.
Okay. Next.
And also the albumin is low, so liver is involved. And case 3 again, case 3 obstructive. Case 3 conjugated fraction is higher, so conjugated fraction is nearly 1/3, more than 1/3. So there is some obstruction component, but enzymes, ALT is elevated. No, I'm not sure.
Okay, so let me answer this. You're pretty okay with the first diagnosis. You will find that all the enzymes are more or less normal, frankly unconjugated hyperbilirubinemia with no reversal of protein, albumin, globulin. So it's a typical case of hemolytic jaundice. Okay. Second case, more or less you have diagnosed that it's not alcoholic. I'm not going with you in this alcoholic term. It's a condition when you are finding in a chronic liver disease, this patient is, but if it would have been alcoholic, you would have found this GGT to be raised. Significantly,
Yes.
there is gamma glutamine transferase is not raised. So it's a chronic hepatitis. That is why the albumin has gone down, globulin has gone up, Ag has got reversal. But this is a mixed bag pattern, but OTPT ratio is reversed. So more chronic is the hepatitis, the reversal of OTPT happens. So initial phase, PT always rises more than OT in hepatitis, but the chronicity, more chronic it becomes, the reversal of these enzymes do happen. Third one is a tricky one, is actually having the similar pattern, but this has happened when a patient is just recovering from acute hepatitis. It's a just recovery phase of an acute hepatitis. You will always find in acute hepatitis, the enzymes rise first, followed by bilirubin. Then enzymes go down, bilirubin takes time to go down. So this is the condition when enzymes has gone down to normal, but bilirubin is yet to go down to normal. So the three conditions are: one is hemolytic, second chronic liver disease, third one recovery phase of acute hepatitis. Next. Yeah, I'm going to the next one. So next I am giving also the similar kind of three pictures. The patient one having total bilirubin is 1.1, but direct is more prevailing more. As you getting the OTPT ratios are also pretty more towards OT, SGOT. But you cannot call these to be a raised bilirubin although, and rest all are normal. Patient 2, here you get high OT and PT ratios, and the rest more or less normal. And this is the condition where you are getting almost everything like similar and no big difference here found. So can you please give me idea about these three bilirubin results and what the diagnosis can be?
Sir, it is just starting of viral hepatitis.
Yeah.
Acute hepatitis.
Acute hepatitis starting.
One, which condition, which one patient?
Patient 1.
I'm afraid it is not. So first of all, you have to understand that this is a bilirubin can happen to a normal person also. It's not a very abnormal kind of bilirubin 1.1. Secondly, you have to find how big difference it is. SGOT is almost 7 or 8 times of SGPT. That never happens in acute hepatitis. Acute hepatitis, SGPT always been in a higher side than SGOT. So therefore, this is a condition actually not a hepatitis at all. This condition has happened when the patient has got a muscle injury or having some convulsion. So this SGOT is solely raised in this condition, which is not matching with others. And as you know, in case of any convulsion, in case of congestive cardiac failure or any other cases, SGOT also corresponds to SGPT a bit, but the ratio is so high. Here, actually, this is the case of a congestive cardiac failure with convulsion, where you can get some backflow injury of the liver leading to SGPT high. SGOT is high because of multi-sources origin. That means from convulsion as well as from liver injury. But rest all are actually having more or less normalcy. Patient 2.
But why is the total protein low?
The total protein is normal, absolutely. So it's not, I'm sorry, it's not 5.4. It is, I think, 7.4. It's a typographical error. So consider it 7.4. I'm sorry. So the second one, what about the second one? Any idea? This is what, ma'am, you were talking about. This is exactly
Acute
so.
hepatitis.
That is the initial phase of acute hepatitis. But you will always find the OTPT ratio being very much in favor of SGPT. In acute hepatitis, SGPT rises much higher than SGO. And what is the third one?
Sir, this can be alcoholic liver.
Exactly,
Alcoholic.
exactly. This is none other than alcoholic liver disease, because which is not matching with any other parameter. GGT has been very exceptionally high here. So it is a clear case of an alcoholic liver disease. So you see, I have given two sets of LFTs in 2 slides. They are almost isotopic, actually. They are very similar to look with each other, but having their difference in if you interpret it in proper logical interpretation, we will find the diagnosis to be very different. So any other questions about the entire presentation? I'm very sorry because the presentation was interrupted very frequently, which actually happened, which actually led to a bit loss of tempo, I should say, for everybody, for me as well as for the listeners. But still, I'd expect questions. Anybody have any questions can come up with.
Sir, actually, in the last session, because of this issue, we couldn't hear. So it would be nice if we get the PPT or some material regarding the first session. There was some discontinuity we couldn't follow in the first session.
Yeah.
So it would be nice if we get the PPT or some material regarding the first session.
I can't hear you actually. Can you tell it a bit louder?
Sir, actually, in the first session, there was much discontinuity and we couldn't follow.
Yeah, there was problem obviously with the connectivity today. Unfortunately, every day is not the same. Today the connectivity is a bit poor over here, so leading to the discontinuation very frequently. So anybody else who would like to? So I'd like to compile the entire presentation and put in YouTube. The previous presentation has also been put in YouTube. So if you really want to have a uninterrupted presentation, I would ask ACCLMP official to actually edit all those portions and make it as uninterrupted as possible. Obviously, it cannot happen like that. So how much uric acid can we report? Sometimes value comes 0. Obviously, if there is a value 0, you should have to have interference. It cannot be anything. You cannot have a 0 uric acid in your body. Although you are having any kind of medication, but still a 0 uric acid is not possible. So if there is 0, there must be some interference. Mr. Avinash, Dr. Avinash.
I wanted to say something.
Yeah, please.
I think we have discussed so many things today.
Yeah.
So for the benefit of all, I think if we can have some case studies on KFTs and on calcium
the session has been so big now. So I thought I
can understand.
First start with LFTs because the next day I'll have serum protein electrophoresis, which will take me less time. So I would do with some case studies of KFT as well as with others, and then I'll start with the that is my plan actually. So
that will be great.
Case studies mainly totally was on LFTs today.
That will be great. Then everything will be covered.
Yeah, actually, that is what I was thought actually, because covering in one day serum iron indices, RFT, LFT, cardiac parameters is too big. So I just concentrated on liver today, and next day we'll have a case discussion on other parameters as well. There are interesting areas of other areas also. And then we'll start the electrophoresis on that day, because I don't think electrophoresis will carry on 1 hour period. So we'll have time for that. Yeah, sometimes total bilirubin comes 0.2, 0.3. Obviously, you can report. I report it very frequently. Somebody, Jagan has asked, may we have your YouTube link or earlier videos? It will be posted in ACCLMP Con very soon, and it will be distributed to you. The earlier video link is already there. and we'll try to edit it and make it as palatable as possible, and we'll share the link. Anybody else? I don't think anybody else have question now. So I hope it's done. Madam Vinita, I think it's done now. Can we call it a day?
Sir, I think, should we end the meeting now?
Yeah, I think we should call it a day because questions are no more there.
Yes,
At
sir.
times,
So-
D bill is greater than total bilirubin. No, it's an interference. You cannot have a fraction more than a high. So it happens basically because of analysis problem. So please don't ever report like that.
So I think we'll call it a day. Thank you
Yeah.
everyone for joining
Thank
in.
you.
And thank you, sir, for such a great talk. And we'll be waiting for more case studies